I'm going to make a few comments about health care. I want to cover a few points about the Affordable Care Act, the importance of social determinants of disease, and the social movements that have led to improved health care in the past, and the reason that they're difficult to achieve. A couple of things about the Affordable Care Act. We all followed this with a great deal of enthusiasm, of course, when President Obama got engaged in the health care policy. And in going to early meetings, there was a discussion that there would be three parts to this health care plan. One would be improved access, one would be improved quality, and one would be bending the health care curve, cutting costs. And most of what I've heard since then has been cutting the health care costs. So I'm not so sure about the quality and access. I do, however, want to mention that there are a few people who will be excluded from this plan. One is the immigrant population, which is not only Hispanic, but also many people from West Africa and Asia. And these folks are not going to be covered under this plan. And the safety net that has traditionally treated both the uninsured and the immigrant populations will maybe become somewhat difficult to maintain because many people will be technically covered under the Affordable Health Care Plan, and many others will be clearly excluded, and rigidity of rules and policies within institutions may become much more difficult to manage for the providers, which I'm one of those. So when we try to take care of folks who are not covered under the Affordable Care Act, we may find it increasingly difficult to provide care for those folks, and the hospitals that serve those folks may take a significant hit. And places like Prince George's Hospital, where I work, could clearly continue to serve the uninsured under the Affordable Care Act, but will not be reimbursed by many of the other mechanisms that have happened in the past, and they may well become very much more in debt than they already are. So I think we have to look closely at how the Affordable Care Act will impact communities and hospitals on a neighborhood level. I also want to point out that the ideas about rationing of health care that go into the Affordable Care Act are kind of confusing. There's a lot of quality assessment, a lot of efforts to draw some lines that will be fairly useful for what really matters when we treat patients. What really is good, we know we have to treat diabetes and hypertension, and certain things are clear. Other things are a little less clear. But one of the big campaigns to cut healthcare costs has been coming out of Dartmouth, where the Dartmouth Atlas basically looks at Medicare and says that there's too much money being spent on this population. And when they look at the neighborhoods, and that it varies from area to area. When they talk about that, they are talking about areas which often had totally uninsured people who now finally got Medicare. If you're 64, you're waiting to get to be 65 so you can get some health care for many places in the country, including Prince George's County. So I think that the increased use of services in areas where previously they were not used is something that has to be carefully looked at, and the idea that some people are doing more for health care than others and spending more money really has to be carefully identified so that minority populations and the poor are not further penalized as Medicare gets attacked. Now, more important than all of the healthcare delivery that we could possibly give in our clinics and hospitals is the social determinants of disease. The social determinants of disease, or I really think of it as the capitalist determinants of disease, are really things that have to do with the broad topics that people have discussed today. There's housing, there's food, there's education. There are many things that factor into really what matters for health outcomes. One of the most interesting things that has been studied in public health lately is the idea that disparities in wealth predict for health outcomes. So that if you're in a country or a state where there are very rich and very poor people, and the extremes are high, the health outcomes are terrible. This is true throughout the South in the United States. It's true in many of the countries of Europe. Compared to us, we're much worse because of the extremes of wealth and poverty in this country than the outcomes that you see throughout the European countries and Scandinavia. So the disparity in wealth is something that I think a lot of public health people are really looking at, and they're trying to move towards equality. And a movie or a documentary that many of you may want to see if you haven't already seen it is called Unnatural Causes: Is Inequality Making Us Sick? Now this documentary has been shown a lot in the last couple of years. It's put out by California Newsreel. And California Newsreel links health outcome data to inequality And it links it also to some things that we don't think about in our clinics and hospitals much. And that's questions of power, control over your life, and stress, which I agree with 100%. That stress thing has become a much more important thing. I used to not think it was too important to my patients. They'd say, I'm stressed out. Now I really listen because I realize that the day-to-day stress of living under stigma, oppression, poverty, racism, that takes a tremendous toll on the body, and more we're understanding that it has the form of adrenaline surges that are constant at low levels and cortisol, and these things are destroying people's cardiovascular system, and it's making things much worse in many other diseases as well. It contributes to diabetes and hypertension, and it's a very serious matter to think about those types of things, which I never really include so much when I take a history from a patient. The people who have done some of the best work on this stress, by the way, is Kamara Jones, a doctor down at the CDC. Most of you probably are familiar with her work at some level. I would say she's not really welcome all that much in talking about these things by some of the politicians that are in Washington. And she had a little difficulty presenting some of her work at the public health meetings last year. And I think that we really have to take seriously the question of racism and how it impacts all of the parameters of health, and study her work and spread it around a bit. In the whole the social determinants of disease process, there's another doctor who's very well known, named Dr. Michael Marmot. And I would also encourage people to pay attention to his work. He's written the WHO pamphlet on solid facts, which lists 10 major factors that contribute to health outcomes, and includes all the things that we all know and talk about today. I want to mention a couple in particular. One is the idea of isolation and social isolation as it relates to poverty, which he defines as less than 50% of the mean income of people and a society. The poverty, the prisons, other things that exclude people, including stigma. I want to credit Howard University with having had 3 conferences in the last 3 years on stigma as it relates to HIV. Excellent conferences, and really starting to deal with the question of multifaceted stigmas that isolate people and keep them from getting treated. We know in treating HIV that if a patient has at least confided in one person, that their outcomes are better. Things like that, social cohesion, social support, community support, things that eliminate stigma are very important in healthcare outcomes, and we need to do a lot of work in this area. Your experience at work, I guess all of you are working except for right now. So when you're at work, do you have control over your conditions or not? This is one of the big issues in these studies that I'm talking about. If you have a high stress but low control ability to do your job, you are much more likely to have a worse health outcome. Taking on the social determinants of disease is a problem that requires a broad social movement. There are many of these things. Each one of them, housing, education, and so forth, require individual struggles under capitalism, but an effort to destroy the system of capitalism and create it with an egalitarian society would solve a lot of these problems much more quickly. We could develop a system that might actually work. The capitalists are not particularly interested in health care for the population as a whole. When they need a healthy worker, they will definitely put some health care into that. When they want to build the roads in the South, they will treat hookworm and anemia. When they want to, bottle beer in Central Africa, they'll decide whether or not to treat HIV or not. Coca-Cola chose not to treat it and just fire people. Heineken chose to treat it and have a stable workforce. These kinds of things that determine our future are really the way capitalism thinks about our health care. So it requires that we have a mass movement for equality, social justice, and these movements in the past have been very successful. They haven't quite gotten to the revolutionary stage, they haven't replaced capitalism, but they have often led to great advances in healthcare. The civil rights movement, the Vietnam War movement, and the women's movements of the 60s led to Medicare. They led to better healthcare in general, more visits. In 1984, I published a paper in the National Medical Association Journal with a couple of colleagues on the fact that these movements also benefited whites. that the things that were documented as coming out of the civil rights movement that meant better health care, more doctor visits, treatment of hypertension, Medicare, these things benefited white people a lot. And they came out of an anti-racist struggle. At that time, we talked about the anti-racist multiplier effect. This is a very important concept, I think, because when we fight racism, everyone in the society benefits. And so in healthcare, there's no exception. My last point is that when the makers of unnatural causes were asked about the disparities in wealth that tracked with health disparities, and they were asked, does this require a revolution? Well, they got nervous, those California newsreel folks, and they kind of tried to think of different things that they could do. They could fight for housing. They could fight for this. They could fight for that. But actually, they were wrong. I'm right. We should be fighting for revolution. We should be fighting for control of our society and not leaving it to the capitalist and the profit-making system, whether it's in healthcare or anything else. Thank you.